All right.
People, please.
Hello, everybody. Jacob's laughing at me because I'm very tepid about my approach with the gavel. Yeah, I've seen one broken, but Doug's on Zoom, so we can't tease him too much. So anyway, I call to order the February 24 meeting of the Special Committee on Academic Health of the University of Minnesota. Happy to have you all here. Thank you very much for attending. I want to say that this is not being live streamed, but the recording will be uploaded and archived to the board's YouTube channel after today's meeting, so it'll be available for everybody then. Just a quick reminder, which we always say, that the microphones are very sensitive here, so and we need to project when we are speaking, but also limit our conversations when we are not, because it will pick up other things. So with that, we'll go ahead and talk about our first and really only agenda item today, because the Governor's Task Force on Academic Health Services has concluded its time, and we wanted to spend some time talking about the recommendations we have. So the task force met 9 times between October of last year and just this past January. I wanted to say just a couple of reflections that I have, and then I'm going to turn it over to Interim President Ettinger and then Dean Toller, Vice President Dean Toller, next to talk about their report, and then we'll go and kind of go over the recommendation. And the purpose is really to have, some conversation about the recommendations and really start to think about, okay, what are our next steps based on that? I'm also happy that Dean Delaney is in the audience today, because she also is a member of the task force, and we'll ask her for her reflections as well. So that's great. I will say, and Regent Turner was there for most of the meetings too, so she can offer. Yeah, so she can offer some reflections as well. First of all, let me just talk briefly about the process. It was
Chair Wheeler, can you pause for a second? As you can see, the screen is frozen.
Okay.
And we don't think we're recording. Okay.
Going now?
Yes,
okay.
Please.
And I won't repeat what I said, but welcomed everybody here to the task force meeting of February 24. And we have one real agenda item here, which is the update on the Governor's Task Force on Academic Health and the recommendations by that task force. I will say, and I'm sure that Vice President Toller and Dean Delaney can agree, that what we had was a very engaged group of just exceptional people on the task force, and really, so the process of it was really robust, really good conversations, really, some different perspectives on things. We were also aided by 2 former governors, really being present and attending basically all the meetings in some fashion or another, and that's, Governor Mark Dayton and Governor Tim Pawlenty, who added to the conversation, and all emphasizing the importance of the university has to the health of the state of Minnesota and the health of the people within Minnesota. So the process was really good. We heard last time at this meeting from Chair Jan Malcolm talking about the broader healthcare context, and that's also included in the report. We're at a pivotal time, I would say, in healthcare. We're not necessarily, we deliver, and I would say the state delivers some of the best healthcare anywhere, and we're not serving people as well as we would wish to. People have trouble with access, there's some inconsistent quality, and there's certainly a challenge for people with affordability. And the people who are trying to serve are also challenged too, with workforce issues, with not enough people, and quite honestly with the people who are there being very tired and exhausted. And then they're having financial constraints too. And I think what everybody did agree on is that the University of Minnesota is critical to help solving the problems and enabling the health of all Minnesotans. So that was one thing that was chimed over and over again. Out of the task force came 20 recommendations too. And they made sure to list how many were endorsed and by whom, and not by whom, but how many was a consensus around the recommendations, and how many were less than favorably endorsed. So that was included as well. So I felt certainly honored to be part of that and around the table. And I think that one thing that is clear to everybody is that investment in the health sciences of the University of Minnesota serves the health and well-being of Minnesotans almost like no other place. So that is clear. So with that, I'm going to turn it over to Interim President Ettinger to talk about his reflections on this as well.
Well, thank you so much, Chair Wheeler. We're grateful for the work of the Governor's Task Force on Academic Health here at the University of Minnesota, and I particularly want to thank you for your work, Vice President Tolar for his, and Dean Delaney. All of you have lots of other things going on, so this was an added responsibility, and we appreciate your involvement. A number of the recommendations of the task force support key steps toward our long-term vision here for a healthier Minnesota. The U of M stands ready to collaborate on the development of world-class facilities to attract and retain globally recognized experts and highly skilled professionals in order to provide the highest standard of care for every Minnesotan. I've appreciated the opportunity to speak at the task force. I had the opportunity twice, and it was indeed great that Chair Malcolm came here last time as well. And I'm grateful for the support that the U of M has received throughout the process, starting with Governor Walz's designation, including the task force's special advisors, former governors Mark Dayton and Tim Pawlenty, along with many others. We will need both public and private partners to work with us to build out a strong academic health system in Minnesota, a model for others to aspire to. I'd now like to ask Vice President Tolar to speak more about the final report and the next steps.
Madam Chair, Mr. President, committee members, it is, in fact, a big week for the University of Minnesota and the health sciences. And I'm delighted to be here to report. But before I start reporting on the task force, I'd like, because I cannot help myself, to report that in the NIH ranking called Blue Ridge, the medical school again is in top 25 and number 9 in public medical schools in the United States. This is not a trivial thing. I can brag about this because this is not my work. This is the work of our research and clinical teams. And these rankings are important to put in a perspective of where we were and where are we going. In 2017, if we compare it to that, since that time, the NIH budget increased 43%. That's a good thing. It's a well-funded, United States are one of the best states, in fact, in the globe to do that. But important is that the funding for the medical school research over the same period of time that it increased 43%, increased 106%. So we more than doubled the ability to get funding from that National Institute of Health. This is, of course, means that we outpaced our peers. That's a good thing. It's a competitive, almost athletic endeavor if you think about this. And we are the leading medical school in the state in relation to research. So rankings are not everything. Rankings are, as I have said before, a lagging indicator. What it means is that we have much better ability to recruit and retain talent nationally. Because they come, the top clinicians, top researchers come because of the magnetic field of the university. And the ranking of the medical school, of course, is one of the most important ones. So now, the other announcement, of course, this week has been the task force and the release of the report on the governor's task force on the academic health. So I'll talk about that today. In August, Governor Walz issued an executive order to call together the task force to achieve the purposes that you see on the slide, and I'm grateful to Chair Wheeler, Dean Delaney, that served on the task force as well. So it's important to remember, however, how we got here. We all remember that this started with the merger between Fairview and Sanford, and I hope, remember too, that we stood firm in our position that this is not acceptable for the University of Minnesota Clinical Practice and Medical School to be owned by out-of-the-state company. We have announced, in response to this, what we call 5-point plan. It's almost to a day. I think it was on the 10th of January of last year, the 5-point plan that was very clear on the fact that Minnesota needs an academic healthcare system, that we are intentional about regaining the ownership of our facilities and collaborate broadly with all the players in the ecosystem of the healthcare in the state of Minnesota. We were grateful, profoundly grateful, that the legislature agreed with us and has House File 402 clarifying that these facilities have public interest and cannot be transferred unless the Attorney General agrees to this. Following that, after getting more attention than we have gotten in decades, the governor appointed this task force and come with the series of recommendations to support academic health. We had 9 meetings, you said, Chair Wheeler, and we have provided many presentations from all health science schools, from consultants, from vice deans on research and education and so forth. Had a very good discussion, very intense discussion at times, which is always for me a sign of good intellectual work. And we have highlighted the needs of the states, the opportunities for collaboration, and the workforce challenges that we face across the whole healthcare ecosystem, all the 6 health science schools. The task force worked through all of these recommendations, and I would argue that there was a varying level of support and potentially varying level of impact. In general, the report does support the university mission in the way that it needs more investment to meet that mission, that we need the tools to advance health and healthcare. It was clear throughout the meeting that this group sees a great deal of challenge or opportunity in how we, that means the collective we, can change how we promote health, wellness, and delivery of clinical care, and that the university is not the only part of this, but it has unique specific charge that has been crystallized by the work of this task force. So we have been left, and this is Chair Malcolm's term, with a large parking lot of ideas and issues that need to be done as well, but there is sort of a gating issue in a way that some of them need to be done first before we can get to the other ones. The 3 recommendations that Chair Malcolm summarized in her executive summary are the integrated strategic plan for the health sciences, to increased investment in workforce initiatives and qualified, perhaps because of the need for more detail, accountability, specificity, support for the university's 3 priority proposals. And that's what I will focus on today. The task force was very supportive of our current and potential work across the 6 health science schools. We are unique. There are 4, as I said many times, only 4 universities in the United States that do have that same privilege and honor to have all the 6 health science schools. So we are, by that and by the work of many, many people at this university, we are unique in the breadth that we have, and even the ambition that's contained in this to be even better as a large ARVA university. It's a great opportunity to innovate. It's a great opportunity to innovate in the workforce shortages by bringing collective work, ideas together, and we are absolutely eager to do that. And as one of the colleagues pointed out in the task force, we don't need legislature to tell us that we need a strategic plan for health sciences. We can start with that right away. And in fact, we have our health science huddle tomorrow, and we will start with that right away. We never stop, in fact, but the crystallization, the focus is important. It's important also that this is co-created by all the 6 science schools, and the deans will exchange ideas, timelines, metrics, and so forth, so that we can bring it to you. And I offer that we will answer, as always, to any timeline, any cadence that this committee and this board would like us to do. But we will start with the Health Science Day in the beginning of March to showcase where we are at and where we can go. The second recommendation that Chair Malcolm brought is the investment in workforce. We will have that as a part of our strategic plan, and we highlighted the request for funding at the Finance and Operation Committee that will meet this afternoon. The part of the university proposal for the task force was the $80 million in academic support to be spent in six buckets that you see over there. I will describe each of these with some additional detail, but I want to clarify that these dollars were never intended to replace the academic support the medical school currently earns with our Fairview partnership. In general, the academic health system, as our consultants at the task force and everybody else that has knowledge about this has assessed, provides similar levels of support that we earn from Fairview, which is about 80 to 100 million annually. But many of our peers, not just the aspirational peers, but really even the peers that we are ahead of, have about double of that investment. It's a part of why this works. This health system benefits from the faculty and physicians that come only because of the reputation of the medical school. And in that way, the excellence that we are able with your support to create can attract top-notch clinicians and researchers, and they then can deliver the top-notch clinical care as a part of the academic medical center. And in turn, the funding that we get from the system, or the academic medical centers get from their related systems, they let the school to invest in research and academics to continue that virtuous cycle. The system also benefits, obviously, from the training programs and provides substantial workforce benefits in the future of the recruitment in future, but also in the quote-unquote cheap labor that residents, fellows, and others provide for the system. Those dollars are cited in the definitive agreement to be for research and faculty retention and recruitment, and that's exactly what we have done with them. This is aligned with the system priorities, and again, we have followed the definitive agreement with Fairview to the letter. Any health system arrangement going forward will need to be able to generate academic support for this work. So the dollars that we requested are different, but are complementary. They are they are helping as we proceed to even greater impact on the service for people who live in Minnesota. The university has proposed a 5-point plan that says clearly that we want to have a world-class academic health system and partner with many players across the state of Minnesota. This proposal is intended to support that goal and to support the strategic goals of the whole university, all health science schools, and the medical school. So the first item is the medical discovery teams. We have successful model and plan since 2008 when the Blue Ribbon Commission put together, this was 2015. 2008 was the Biodiscovery District. The Blue Ribbon Commission, the medical discovery teams have generated grants, faculty, new knowledge, and we propose that 25 million of that 80 be focused on these new multidisciplinary teams that brought so much good already to the university. The second item is the 20 million that would go to underserved communities. As Chair Wheeler said, we are probably the place in the state of Minnesota that can answer why is it that it's almost devastating to ask a question today, what is it to be sick in the United States and be poor? We all know from personal or professional lives how tragic that equation can be. So to advance the equity is clear priority for the state, for the university, and we already have several clinics, such as the Cook that we have for more than half a century, our family medicine clinics, our dental outreach clinic, nursing clinics, all that exists, but we need to partner with other systems as appropriate to fill in the gaps in service and to really provide more training opportunities in the underserved clinical delivery, because that's how you retain the people. That's how you train them. That's how you make it a part of who they are, part of their calling, if you will, that they will remain attached to that goal of their life. $10 million is for primary care transformation. We have heard it multiple times in the task force, and it's clearly a priority for the faculty and something that we have been working on, but also it's a part of that academic healthcare system. We need the referrals, we need the networking across the state, and that will benefit the physicians and providers, especially in the rural areas, and it will improve our ability to retain the best and the brightest so that they do commit to serve in the underserved area of the healthcare. The 15 million would be for the workforce development programs. We believe that there is a necessity to expand the class size. We talked, and this board has been very generous in supporting our expansion in, say Cloud, the pathway to the Minnesota state and private colleges. And this all will be informed by the strategic plan and conversations across the state with multiple of the players, smaller healthcare systems and large ones as well. $5 million is for the Center for Learning of Health System Sciences. This is one area with an overlap with our academic support from Fairview. We have started this about 3-4 years ago, and it's an excellent example of the collaboration across the health science schools, because this is a collaboration with the School of Public Health, and we have started working from within the Joint Clinical Enterprise to address the clinical inefficiencies and outcomes in real time. We have a national expert, Dr. Genevieve Melton-Mew, Dr. Chris Tignanelli, and many others that are leading nationally in the ability to lead in how we look at data. It's not just AI, it's not just ChatGPT, it's more than that, and it clearly is necessary if we are sincere, which we are, about the work-life balance of nurses, of clinicians, dentists, and everybody else, and also in the generating a high-quality, high-velocity decision-making in the clinical realm. The last component is $5 million for innovations across the health system. My favorite example is Dr. Colonel Greg Bielman, who has transported his amazing ability to manage military healthcare into a pre-hospital healthcare. So he was the one who opened the door for me in understanding that healthcare in rural or distant, greater Minnesota, greater US is not that dissimilar from the battlefield. You have to stabilize the patient where she is, and then make sure that she gets transferred to the right site. So we are working with all the hospital systems across the state. Maybe I'm missing one or two, and we are taking this as a part of your charge that you gave to us to expand to the rural areas where it takes some time to reach the hospital. Now, important for these is that they are not duplicative. They are all of benefit to the state and our patients. They all advance the academic mission. They are aligned with the strategies that we are in place for the schools and our clinicians. So the university's other proposal to the task force were related to our care facilities on campus. Some of you, Mr. President and others, have given me the honor to be the tour guide for the hospitals. Most recently, Governor Dayton this week, and everybody agrees that the facilities that we have to work in are too old to support the patients needing our care. Everybody has been stunned by seeing the patients in the hallways, the boarders in the ED. We have 6 or 7 cots in the garage for the ambulances. They are filled almost every day. Sunday, it was the only day that we didn't have patients there. Many patients wait for getting a bed in the hospital for hours, days, sometimes weeks. We don't say no to patients. This is different from other healthcare systems in the state, and that's why this is the service on your behalf to the people who live in the state of Minnesota. So we need facilities that are on par with this, because the facilities, the fact that this is old and small and all that stuff, is only important because we provide something that nobody else does. We provide unique, innovative healthcare that is not available at other healthcare systems. We provide the other healthcare as well, but I would say about 20% of what we do is just impossible to provide somewhere else. You can look at the heart-lung machines, the ECMO, you can look at transplant, solid organ, or my day job, the bone marrow transplant or cell and gene therapy. There are multiple things, that really the best care is provided at the University of Minnesota. It's also that mission that some patients and even some people in the audience commented that this is a different feel that you come to the university hospital. This is not just the clinicians. This is really people who see you at the door, who walk you to the room, people who clean the floors. There's a different ethics that comes with serving in a land-grant university. So we need a top-of-the-line equipment and space to recruit the best and the brightest and to meet the needs that our patients have. And they will only increase, and we need to be ready for all that innovation that's coming from us and from others to put it in practice at the bedside, in the operating room, in the intensive clinical care. A majority of the task force supported the planning for the new facilities, as was the part of the 5-point plan, and investment in the current facilities in the meantime. This slide shows you the old buildings and also the blueprint, visionary blueprint for the new buildings, for the new hospital. I can tell you that the idea of my colleagues that deliver near heroic acts pretty much daily with the patients and with the administration of this is one of the most energizing things for our faculty, and it will certainly prompt even more attention to the productivity, quality, and outcome results that we have. To wrap this up and turn back for our discussion, our next steps are, first, as I said, the Finance and Operations Committee this afternoon. The legislative session starts on Monday. I was pleased at the interest of all the university desks, and thank you everybody who was there this morning for the breakfast, for the legislative breakfast. And we are certainly working with Fairview on the day-to-day business, how to best establish a long-term relationship. And we are always exploring new ones. You've heard about the CentraCare. We are clearly looking at our partners at north, Ainsley and Houghton drive me to Duluth every other week, it seems. And so Essentia and St. Luke's are very interested in us as well. And there are even systems in Wisconsin that would be like to seek, some kind of a productive partnership. Thank you, Chair Wheeler. I turn back to you.
Great, thank you very much, Vice President Toller. And I think I'll invite, if you're all right, Dean Delaney coming up and just giving your perceptions as a task force member too, and then we'll open it up for questions, discussion, emphasis, and whatever the committee desires.
Thank you, Chair Wheeler. And as several have said, it indeed was a full honor to serve on this task force. Before proceeding, Jakob, congratulations to the med school on the increasing in the rankings. And as everyone knows, this is a core component of all the 6 health sciences schools, not for rankings in and of themselves, but it represents one measure of quality and how we, if you will, measure up nationally. So congratulations to all of your faculty and staff. And thank you for the summary, Jakob, on the recommendations. There was an overwhelming acknowledgement of the essential existence and contribution of the University of Minnesota Health Sciences. Overwhelming support and recognition of that. There was also the unwavering import of partnerships, as you mentioned, President Eppinger. So the call consistently was for an academic health sciences, as Jacob mentioned, one of 4 in the United States. So what is the capacity, the desire, the capacity, and the need for health sciences, if you will, to partner and to fill that gap on the pathway of full service to the state of Minnesota? So the task force constantly focused on, first, the people of Minnesota and our commitment to the health for all people in the state of Minnesota, with a high priority on underserved. So the recommendation that you saw related to the strategic plan is such a beautiful, timely, urgent call to action on how we support and engage in full partnership throughout the state with systems, as Jakob mentioned, but the breadth of other health-oriented services in the state, and then clearly define how we potentiate that and extend beyond for the health of the people of Minnesota. Along that line, I applaud Jan Malcolm's leadership. And one of the statements she regularly made is This is not about more. This is about outcomes. So we can keep adding services without the outcomes component, where our impact can be questioned. She also regularly emphasized it's not about how it is now. We are at an absolute defining moment to frankly redefine partnership, healthcare, and the full service to the state of Minnesota. So it is about the future, which doesn't mean years and years. The dire need is absolutely now. Regent Turner, thank you for attending most of the meetings. I particularly draw that out because this task force also raised the import of workforce. And we are in an absolutely unique position across all of the 6 health sciences, schools and colleges, to address the workforce needs in a very robust, creative, and partnering way. So I think those would be the key comments that I would add to those that have been shared. And end with the respect for the University of Minnesota was lifted up constantly. The excellence that exists here was lifted up. And the call to support with a bold strategic plan was affirmed. Thank you.
Great. And I would say thank you too for your service, Dean Delaney, and for quite honestly modeling collaboration. Because one of the things we looked at was the collaborative nature of the nursing school and how you have partnered with almost every organization, I think maybe every organization in the state, in that way. And so thank you for also modeling that as well. So appreciate it.
If I might add 2 comments, Chair Wheeler.
Please.
Since you mentioned that. Yes, 2 comments. One relates to the Center for Nursing Equity and Excellence. We partner with all schools of nursing in the state of Minnesota, public, private, proprietary, across the continuum of preparation of nursing, and with most health systems and other leaders in the state of Minnesota. The second that we lifted up is that we have 10 collaboratories, academic practice partnerships, and those are with the breadth of systems, many of which you mentioned, Jakob. So thank you.
Thank you. Thank you very much. With that, I wonder if, Regent Turner, I could turn to you first because you observed this, and I'm curious about anything you want to bring forward to this group as we discuss these recommendations.
Well, as a bedside care nurse, Chair Wheeler, I have to start off with kind of a taking off of Dean Delaney. And I remember her saying to me that we're going to be like 4,000 nurses short in the upcoming years. And I don't know if that is statewide or if that's
Actually 30,000 statewide.
30,000 statewide. And that the collaborative plans that are all the nursing schools across the state need to take, they're literally, we cannot afford to have even one single nursing slot open, no matter where it is in the state. And this is where we have to break down those barriers of being so possessive. Because to have even one school of nursing that's got 5 slots open that weren't filled, that's 5 less nurses out with the workforce. And this is what I hope, this is an example of what I hope when we're talking about doing things differently. Because the same could be said for physicians and dentists and all. Every single healthcare profession I see at the bedside is lacking workers. And so going into the future, we cannot have any of our schools with empty slots. Because the other thing is if you have a young person who wants to go into nursing, and they'll maybe hold on to that dream maybe a year, maybe 2, but if they're denied entry too long, they go find something else to do. And then the other point I wanted to make is that last meeting when Vice President Dean Toller, and maybe you had said it before, but you really said it clearly, that we are in the business of administering to the underserved, and that, rural access has been a problem for years all across the nation. But the other part is inner city access to care. It's kind of like nobody wants to pay for the inner city care. And the U of M, like HCMC and my hospital, we do to the inner city. And inner city hospitals all across the nation are taking a beating because they're wanting to move all the access of care out farther. And so we have to decide as a state, if not a nation, is healthcare a privilege or is healthcare a human right? I think at the university, we believe that's a human right. So those are my takeaways.
A great takeaway. Thank you, Regent Turner. Thank you for also being so present there so much of the time. And it's clear that the workforce, and the criticality of the University of Minnesota on the workforce that cares for people and reduces suffering, and is profound. So that is very clear. It's also clear that we're so dependent upon it. I mean, I think of those 6 professional schools, I believe we're the only pharmacy school, we're the only public health school, we're the only veterinarian school, and I think I'm forgetting, only dentistry school, yes, right? I mean, we're the onlys, here in the state. And so we have to, recognize that critical need. And I think also as a public university, a big part of our mission, as Regent Turner emphasized, is serving the underserved. And whether that be our neighbors or in greater Minnesota or wherever, that's a big part of it too. And that's why some of these investments proposed actually tie to those needs directly. So thank you for calling that out. With that, I'm going to open it up for questions, comments, issues that people want to raise. Yes.
Thank you. Well, first of all,
Johnson.
Again, to Regent Wheeler, Dean Tolar, Dean Delaney, thank you for your good work. As I am thinking about this, what I'm thinking about is kind of the next phase, which is communication of this and selling it and taking it out there so that we're going to need the support of the legislature and others to make these things happen. So how do we communicate with them, and what are some things I think we might emphasize? One of the things that comes to mind is I think when we're talking about what we do, I think you should say clearly that the University of Minnesota is the public academic health center in this state. That's the most accurate statement. And it's also important as we talk about and communicate what we're doing. So the public academic health center in the state. And I think as we look at those 6 priorities, they're all important. And, to those of us who are physicians or here or whatever, the research stuff is wonderful. But I'm saying as we try to sell this to the citizens of Minnesota and to legislators who have to convince their constituents that giving more money to the university is, something that's going to serve them. I think we ought to look at kind of just the order in which we say some of those things, that we don't put the research thing at the top. I would tend to think we could put it at the bottom. It's foundational, so that makes sense. But I think we need to say we're serve the underserved, the primary care, all the things we've talked to. Those are the really, really important things that you do that are critical. And I think that is not a hard sell to our citizens and to our legislators. So we think about that. And then as we present it, I think, and we talked briefly about this at our meeting this week, but I really think storytelling is an important part of that. So you take something about, the underserved on the primary care, and then here's a story. Let me tell you how this plays out. Here's a person or here's a family in this area. They couldn't get care anywhere else. Here's to care of them. Here's what difference it made, or here's what we're doing in primary care. Here's how we're getting out into the rest of the state. I think if we do that, then we'll be far more likely to be successful in getting the funds that we need to support what we're doing. So I just think we have to think strategically. Not so much, it's so easy for us because we have our perspective. We have to think about what's important to the people we're talking about. How do we convince them? And I think we can do it, absolutely. But I just think we should think carefully about that and kind of tailor our plans. And Melissa can help, all of you can help with that. And Dean Delaney, wonderful stories are. It's just, that's what I would recommend we really give good thought to.
Thank you so much, Regent Johnson. Here, it's about what's the need and how do we serve? You know, the biggest leadership lesson I was always taught is never forget who you're serving and why.
Right.
So what are the needs out there, and then what is our unique role to play to meet those needs?
Right.
And through that, you know, really making sure we are the public academic health center in the state of Minnesota. We do have an obligation in many respects, morally and otherwise, to serve the underserved.
Right.
And to tell those stories of those people successfully served, you know, is powerful as well. So thank you for that.
Those things speak, I think, people.
Okay, great. Other questions or yes, Regent Verhalen.
Thank you. And this has been really helpful. You know, it's one thing to read the words on the page of the task force. It's another to hear some of the background and really some of the intensity and passion in each of these items. To touch on something that Regent Turner talked about, you know, and tie it to what you just said, Regent Wheeler, about we're the academic health center of the state. The individuals that come to the University of Minnesota for academic health would not be able to practice in those areas without many of the resources that are coming from other schools within the state as well. I'm thinking particularly about a lot of, and I know you were not ignoring them, but I think it's really important that as part of this discussion, we be really clear that as we are working at the University of Minnesota to instill in these graduates the public right to healthcare, that they are then able to take that out into the workplace and also share it with those they are training alongside. And the importance of being able to commit themselves and those around them to remembering that we are all human and we all need to actually take care of one another, because that is the only way that we continue to get better, both health, in culture, in people, in personalities, and all of those things. And that is a critical piece. I know our public health dean and others who've been before us have talked about the importance of public health versus treating. And I know you've talked about those as well, Dean Tolar. And I think that's so important for us to keep in mind that there is more than just a preventative. I need to go to my doctor every year to get my annual checkup and those types of things. There is a preventative piece that we as members of this larger community can all be a part of. And I think carrying that forward in those programs and in the training that occurs is really important.
Well said, thank you. I mean, there is a profound recognition of the uniqueness of the interprofessional nature of the University of Minnesota and those schools, and that's why the recommendation of the interprofessional strategy was so profound. It's good to remind that, and it's good to remember, but even schools outside the University of Minnesota that, require that connectivity and things like that are clearly needed as well. And I'll say provider systems. Many of about a third of my training, even though I'm university fully trained, was done outside of the university. So you have to remember about how we connect and relate to both inside our university and with others outside. It's a good reminder. Thank you. Other questions? Yes. Board Chair Mayron.
Thank you. I just wanted to support what Regent Ruth Johnson said about our communications with the legislature, with our request for the $80 million, and the need for personalizing the situation down to those who are receiving our care, and the importance of storytelling. And it was really brought home to me today when I was at the legislative breakfast. I was seated next to a legislator I was asking him about why did he become a legislator, and it all had to do with his personal experience as to what drove him to do this public service work. And he talked about how on subcommittees that he's been on, how he will share that personal experience to drive home the issue that is before that particular committee, where they may say, we should bring in people who can tell their story. And he said, I can tell the story because it happened to me. And he explained that to me, and he explained his background, and it really resonated to me. And I said, what do your fellow committee members, when they hear the story from you, how do they react? it's not lost on them at all. They really end up connecting to it. So I do think focusing on what legislators want to hear, which is in particular, how are their constituents going to be cared for on a going forward basis, I think is a really strong story to tell. And we all understand the importance of our research, and if without our research, we can't provide the kind of connection and care that we need. But I'm not sure that's what matters to our legislators. They want to know, how are you going to bring the care to the underserved and to others as well? And those are the stories we need to be sharing with them.
Yeah. Thank you very much.
Can I?
Yes.
Chair Wheeler, this is wonderful. Thank you for making these comments. I'm going to touch on a couple of things. One, if I may, the prevention that Regent Verhalen, you talked about, and the public health, it has to be seen, in my opinion, as an entry point to totally new era of medicine. What I have seen, and we have now generated at this university, not just medical school, College of Engineering, other parts, of the university have generated an opportunity that for each one of us, there are about 5 or 6 stages in adult life that we will develop a near fatal condition. And what can be done right now with biomarkers and with other things is that you recognize it before this becomes clinically evident. Cancer is one, heart attack is another one, spinal degeneration would be another one. And you can, with a very limited treatment, with a very limited intervention, you can move that person from the part where she has the disease that would have progressed to a near fatal condition to health. And you can do it a couple times. So that's where the public, is the beneficiary of that enormity of the human understanding. And I think that changes how we talk about, and last time in this committee, you made a very good comment, that there is a big difference between clinical revenue and clinical care. And many people in the United States are essentially victims, of idiosyncratic business where the price tags don't matter. There's no free market even, in healthcare, and it's such a convoluted system that it's nearly impossible to navigate it on our own. Now, what I see as a possibility is that more and more payers will look at the whole health, whole person health, value-based care, in other words, and we'll see this, with a certain capitation limit, about 23% that makes it lucrative, and see it as a good business model. Because what's really important to your comments, Regent Turner, is I think that, yes, it is a privilege to be, or it's a right to have good health care, and everybody should have it, no question about it. But what some people, not you, but some people forget that there's no difference between a right and obligation. Because what it means is not that we all agree morally, ethically, and everything else, that it is the right thing, for a poor family that's immigrant, doesn't speak English, to be taken. It means nothing unless we say, these are the funds. This is the unit that's going to pay for it. It's totally hollow unless we connect the two. So behind some of this ask is that we are, with humble position to the state, we assert that if we are to be the agents of change, and agents that will provide that care, we need help. And it's not a Band-Aid, it's an investment. This is how we get better. To your comment, Regent Johnson and Regent Mayer, about storytelling, one of the, my practice has been humbling in many different ways, but one of the most humbling things for me is New Year's Eve, or, that because I get, as many other clinicians do, I get about 2 dozen, maybe 3 dozen these holiday cards with people that I can tell you would be not living unless they came to the university. And it has to do with the fact that we deal with, the rare, fortunately, but, if it's your family, it's everything you see. occasions of relapsed leukemia or some genetic disorders, but it's a very clear personal story, and I can tell you every single one of them. I know all of them, and can empower this as anybody else that does medicine, you and others, has that. So the storytelling, the fact that the medicine is a personal quest. Best clinicians that I've ever seen have several things. They take it personally. It's about them. They become who they are in the process of serving. They are fluent in basic science, to your point about the research and your point about the research. I just need some help from Melissa Lopez, Franson, or for somebody, I stop saying research in philanthropy discussions. I say this is what it is. But I can assure you that there's no difference between the research we do and clinical care we provide, as there is no difference between the education we provide and the clinical care we provide. It's the same thing. And that's what makes us really, really effective, because the students that we educate will then follow and educate others and others. So this is a gift that is sort of the perpetual virtual circle. Thank you, Madam.
I want to move us, thank you very much, because it does is the personal impact, that resonates the most, just like the personal story that the legislator told you, Chair Mayor. And so I want to move a little bit to, we talked about communicating this effectively, which is part of our next step, right, is communicating this effectively. What questions or things do people have about moving these recommendations forward now? So I want to know, okay, how do we move forward? One on the communication side, what other questions do people have? I have one myself, but I saw Regent Turner, your hand up. Yeah.
I have a question. Just as a side note, before I ask my question, to Dean Toller, the pandemic was a perfect example of research and the front line working at the same time. Because everything that came out, as soon as it came out, even hydrochloric, whatever that name is, we even tried that for a week and a half. And so it was a perfect example of research being done and then us just praying for the next cure.
Yeah.
And ultimately the vaccine. But my question, to get a little bit controlled here, sorry, I get PTSD big time.
Understandably.
Do we only tell the good stories? I have been to the ED over on the West Bank. I have seen the garage. I have seen the garage that multiple kids had to hang out in the hot summer because that was the only place to go. I have seen them in the hallways, et cetera, in that ED. Do we only tell the good stories, or do we tell of the need? That's my question when we're communicating.
Regent Turner, thank you. I also been in that position, to see people dying on iPad, and I certainly, have a deep admiration and respect for your work and experience. The answer will differ, to your question. My personal answer is absolutely not. You say the bad stories too. It's actually really important to make people uncomfortable. It's all good, to have a group hug around, some of the great accomplishments we have, but unless you make it real to people, and you make it real by both the extremely positive ones. I had, for example, in my practice, I had half a dozen women that were told they will never have children, and they have, and so forth. So you say the exciting stuff, but at the same time, you have to say, this is what's wrong with this system. And it depends, how one, is free to do this. But in some of the discussions with the legislature, for example, I used to say, and I was told not to do it anymore, what I call deletion experiment. What you really need to see is not what we have now, because it's given for granted. It's like a fish doesn't recognize the water it swims in it, right? You have to recognize that if we do not get this help in programmatic, it's very clear. We need programmatic investment and we need capital investment. If you don't have it, I can tell you exactly what's going to happen before the end of the decade. You will have none of it. And I know this for a fact because there are places that want me and others to go and build something that was so successful at this university, and they can't. You cannot buy it. You have to have that layered, disciplined approach to this. And I had 5 minutes downstairs in their heritage, so I saw the quote from Vice President Mondale. This is the honesty, decency, learning, and service. That's perfectly said. That's what he said downstairs. And that's what this university is about. So the deletion experiment is if we don't have this and we just wait, I can tell you exactly what's going to happen.
I think you could share a story on that too. Here is what happened. Here's somebody, if someone wasn't able to access care, didn't have an emergency, didn't have the right thing. And what happens? So if we don't provide those things.
Yes.
So I have a question. I'll precede this by saying, and I appreciate that there were 20 others from the University of Minnesota who applied to be on the task force. And I will recognize Dean Toller for having us meet with those 20 people about every few weeks, during this time period, which was great. So we got their insights as well. And one of the things after the recommendations were coming forward is her name is Katie, one of the people who said, why don't we do this interprofessional strategy development now? That's something we can control. And so I'm curious about what are the next steps. I think this committee is going to be intensely curious about what does that strategy look like? And then how flexible are the incremental investments we're asking for? Because the strategy usually informs what investments you do. So, look at the needs, look at the strategy, look at the investments. So I'm just wondering how we approach that, what has already been done, what can we expect to see by when? And then I'd also ask what the resources you may need to actually make sure that ties together with all the 6 professional schools and even, quite honestly, talking about value-based purchasing, even things like the Carlson School. There are other assets in the university as well. So wondering how we'll approach that. That was a clear and 100% endorsed recommendation by the task force.
Chair Wheeler, thank you very much for the question, and absolutely happy to answer it. I commented a bit in my comments about this, but let's unwrap it. It's very simple. There's no vision that I find invigorating that is not attached almost immediately to the action work product. So what we do is, we have a very active interprofessional education, training, and care already. Cook is, for the last 50 years, has been the site of interprofessional care. We know how to do it. We know what to do with this. And that's why we sought multiple investments, for example, in the Cook. And that's the example, Regent Turner, of the inner city care for underserved. So there's not a lack of knowledge or lack of practice. In fact, I would say that out of the whole spread of the potential that we can do in interprofessional, more than a half we are doing already. Dean Delaney spoke about her collaboratories. There are certainly, multiple extensions of public health, across the state. There's great connectivity to Minnesota State, in general, and there are geographically connections already. That's the first part. The second part is that the interprofessional education, based not necessarily on the accreditation bodies for our individual schools, but rather on a tradition and legacy that has started already at the University of Minnesota, the Interprofessional Center, for example, and part of which resides in the Provost Crossan's office, and we collaborate on this, has already been built in this way. So we are not starting on a white page. This is really to expand and deepen what we have been doing already. There are many things that we need to do that we have not done yet, and that will require metrics, timelines, and deliverables. But since we have done this all along, I'm quite optimistic about this being done. The last comment I say is that I'm not the only person who is a little tentative about the strategic plans in general, because the ones that I have seen are these bricks, that go, in the bottom of the shelf, and nobody looks at them again. What I'm much more, in favor of is, 2-pager. It's not that difficult. There's nothing mysterious about this. If you want to get something done, these are the 21 things, that need to be done. You say, you focus first, right? So you say, this is what I'm not going to do. It's really beautiful, it's shiny, but that's focus is what we don't do, not what we do, I think. And you focus on the three and you get them done. And once you get them done, the teams have been trained around the interprofessional education, care, and so forth, and then you move, forward from there.
And I appreciate that, and I think you are doing a lot already. I think that I personally, and I think maybe some of the other committee members, lack the clarity on what that is that's being done now. What's the inventory of the current work that's being done? You said that there's a needs to do. I don't know what that looks like, and I think the task force was intimately interested in that. And I do worry about sometimes when then there's lack of clarity about the direction and what your key focus areas are, then you can go in too many directions. So I'm wondering how we take, what you are doing currently, what you think needs to be done, and have that in a strategic plan so we know what we should root for, endorse, advocate for at the legislature, and all of those things. So
that's a very good suggestion.
So wondering how do we support that? Development, as a committee and as a university. And that's why I asked about the resource question. Sometimes you need, to tie these all together takes sometimes conversations, and takes a lot of thinking and a lot of interdigitation, to speak of. So I'm just wondering, what can we do as a university, as a committee, and to get us to the point where that's clearer to people about what that looks like.
Thank you, Chair Wheeler. You're absolutely right. The biggest help from this committee to us would be to all the 6 health science deans and other deans across the university in the interprofessional space is to have the privilege of your attention, say, the next meeting, so that we can come up, with the inventory. That's not difficult because we have it, and with focus. I think that the focus is absolutely paramount in any endeavor, and this one especially. So we can come with 3 things, that we want to do this year, and 3, by the end of the decade, and that may be, what is going to come, as I said in my comments, out of the discussion of all the 6 health science deans. We have these huddles. We have one tomorrow. We meet very frequently. Dean Wellich from College of Pharmacy has led our effort in essentially every dean. Each dean put on the table the 5 or 6 things that they think are most important, and then we crossed, at this and said which one connects us all, and it was anybody rural healthcare, and so that's where we started. And that's where we focused, in this. But I certainly welcome your quest and ask for us to come to you, to the committee, and say, this much money we need to do this, and so forth.
And I would welcome other comments, too, about what other committee members think of. What's our next step to best support the advancing these recommendations? Yes.
I would go to an extra meeting just to be able to hear that, to get that down and dirty from all of them, to be like we're in on your mini huddle, to see exactly what, because I'm with you totally, Chair Wheeler, that we have got to have I got to be able to write down number 1, number 2, number 3, especially when you're talking to getting up to the hill. We have to have it very specific. We have to paint the picture. And so, like I said, I would voluntarily go to another meeting just to be able to hear all that.
Advocating for that inventory
Yep.
of what's currently happening and what people think needs to happen next, and then subsequently developing that into, probably has to be codified, like here's where we're going. Yeah.
That's right.
Okay. Other comments or questions?
I think that, if I may, I think we had great success with Impact 25 in terms of developing a vision and a strategic plan, and then create the metrics for accountability. And I don't much care how, I think it starts with the strategic plan, and I don't care how long or short it is, but I want one. And then I want to know who's going to be responsible for advancing each of those components of the strategic plan, and how will we know that we've met them or not met them within whatever period of time to have the metrics. And to the extent we've already made good progress on a number of those, great, that can be part of, the background to the strategic plan. But I think it's critical, and I see the role of this committee is basically being a sounding board for the administration as you develop it, but also to hold Dean Toller, the administration, accountable as well, to hold your feet to the fire, to make sure we get this, and the sooner the better.
Great, that's great. And I think that's a great, the Impact 25 was a clear roadmap and has us all eye on the prize of how do we know it's working? Well, we have measures of success to know that it's working. So that's a good model.
And I will say, I don't think it's a document that went into the bottom of the drawer, which you see many of them. But I'm not sure, at all levels of the university, it didn't go into the bottom of somebody's drawer. And maybe the people who have boots on the ground who have to implement whatever's within the Impact 25. So making sure that there is understanding and buy-in, and hopefully sits on the top shelf or at the end of the desk that somebody can refer to, is where we want to make sure everyone who's part of implementing the strategic plan understands what they're doing against that plan.
Great, thank you. Thank you very much, Regent Mayer. Yes.
Yeah, I guess on that point, Chair Wheeler, I think you need to balance the timing needs potentially of wanting to have good conversation points for this legislative session, which kicks off Monday, versus, this was a serious and legitimate recommendation of the task force to, for example, do this 6-school assessment. And I don't think we should be asking the deans, I'll do it really quickly, throw this together in a few weeks so we can get on the Hill and quickly talk about it. I think it's going to take a little time to do the job properly. I just want to make sure that that time is provided. And same thing in terms of when that group would come back to this committee. I wouldn't schedule that out in 3 weeks. I think they're going to need some time to do it.
Yeah, I think that's really wise. And, this is just a recommendation that's just come forward Monday, the final task force report, but a really needed one, for making sure that we're making and articulating the investments in the best possible way. That said but there are some critical needs there now, and need for investment. And that was also recognized by the task force as well. So you can't wait on some of these things. There's a risk of there's a garage where patients are being held. So there are some of these critical pieces now as well. All right. And by the way, that $80 million investment that's proposed on the categories that Dean Toller walked through, that's incremental investment in the University Health Sciences. And the approval of that investment going forward, as a Board of Regents, will come through the Finance and Operations. So they're basically the appropriations committee, for the Board of Regents. But I'm wondering if there's any questions about the proposed investments as Dean Toller outlined them. These are areas that cross-reference to a lot of the needs, right? It's workforce, it's underserved, it's a lot of the things that we've been talking about. And that was recognized too, I will say, at the task force meetings as well, is when the university broke down those categories, they lined up with the critical needs that were articulated during that time. Okay. Anything else that people want to bring up? I think it's done a good job talking about, on the communication side of things, on thinking about next steps for the interprofessional strategic plan, on the need that everybody recognizes for investment in the university, and that all of healthcare is in peril if we don't actually, make sure that investment is made. But is there anything else that we want to make sure we talk about here? Yes, please.
Small thing. Maybe with those 6 things, you might make a pyramid or something, and then I would think it would be helpful just in one image there that you have the 6 things, and then the amount of money that's being asked for each of those, right? They tally up to 80, is that right? So I don't think that'd be one quick graphic that might be nice to have.
Okay, great. Thank you. All right. Any other comments or any other business before us? If not, we will stand adjourned. Okay, thank you very much, everybody.